I have been given a topic on chronic total occlusion of coronary management strategies and varying technique. What is the definition? 99% stenosis of a vessel, duration more than 3 months, and TIMI 0 to 1 flow considered as CTO. Histopathology. What we found? In the histopathology, we found organized thrombus, fibrotic plaque, calcified lesions, proximal or distal fibrous kept, and microchannel in the occlusion segment. These are the pictures. These are the pictures of chronic total occlusion. Chronic total occlusion, we call it CTO. Why bother to do PCI? Because it relieves angina or ischemia. It gives freedom from subsequent CABG, improved airway function, improvement in event-free survival. Chronic total occlusion reconstruction relief. There are a number of trials from earlier dates to till now, and you see the patients, more than 80% of the patients remain asymptomatic. Meta-analysis of CTO, what it gives to us, that is the mortality. The p-value is very significant, but in case of myocardial infarction, it does not improve. Subsequent CABG is reduced and residual angina is far better. Statistical, all three are statistically significant except myocardial infarction. Medical treatment decision CTO trial or decision OCT trial, what it says? It says medical treatment was non-inferior to CTO PCI. Okay, let us see. Progress CTO. What is the scoring system? This is a scoring system. Its success rate is 92% in among 781 procedures. And what this says, the success rate depends on risk scores. The more the risk score, you see, the more the risk score, 1, 2, 3, 4, and 4 to 6, risk score 4 to 6. The more the risk score, failure of PCI is more. Success rate is 85 to 87%. Now, how to select patients? Symptoms. A CTO with well-developed collateral is hemodynamically. Now I can. Yeah. Close this. It is not good. Symptoms. A CTO with well-developed collaterals is hemodynamic similar to 90% coronary stenosis without collaterals. Significant recovery of ventricular function is expected. Viable myocardium, recovery of LV function depends on the presence of hypertonic viable myocardium. And success, if the likelihood of success is moderate to high, that is less than more than 60%, and the likelihood of completion less, PCI is encouraging. Barriers. Barriers are complication, failure rates, economic burden, CIM. Economic burden, repeat procedures, fluoroscopy and hardware more. Complications, impairment of collateral flow, spasm, sharing of side branches and collateral by dissection, distal embolization, dissection with branch occlusion and perforation, intravall balloon expansion, slight branch dilatation, damage of new channels, connecting vasa vasorum. Guidewire entrapment sometimes occurs. Subacute vessel occlusion, 8% occlusion within 24 hours versus 1.8% of non-total occlusion. And CIN is a complication, reduction is more. Reasons. So reasons why we cannot do the procedure. Not able to cross the guidewire is 63%. Long intimal dissection 24%, dye extravasation 11%, balloon did not cross or dilate 2%, thrombus 1 to 2%. Posterior success rate is favorable when tapered stem, functional occlusion, pre or post occlusion, pre-collaterals is not there. But unfavorable, stump absent, total occlusion, side branch occlusion and bridging collateral is there. Now, guide wire selection. First, key to success. This is the first thing to be considered. For effective guide wire manipulation, coaxial load resistance of guide catheter important stability and backup force remains. In case of RCA AL guide wire with sidebands, Shepherd-Cook RCA for AL1 or 2, proximal RCA lesion, GR avoid osteal damage, extra backup XBEBO, LCA for extra backup and XBU, LCX short left main, AL1 or L2 better support coaxial. Guide catheter, 7 front, 8 front guide catheter, superior backup support needed in CTO. Intertwining is less common while using parallel wires. Switching over the device like rotablator is easy. Permit better constant injection. Radial approach usually is not preferred for CTO. Side hole guide wire catheter is successful for RCA. Maintains perfusion up to the sinus road artery and conas branches. Classification of CTO. Wires, guide wires. You see spring coil guide wire, hybrid guide wire, hydrophilic guide wire, hydrophilic guide wire, spring coils wires, CTO wires. These are the classification. Non-spring coils. Which one to be selected? Commonly used CTO wires. Selection depends on penetrability. Penetrability is the ability to puncture a lesion. The stiffer the lesion, the more penetrability is required. Penetrability depends on tip load, tapered tip, wire support, microcatheter, over-the-wire balloon, anchoring technique, child in mother catheter. Lateral support of the wire. Pushability is the amount of force needed to advance the wire. Pushability depends on what? The characteristics of the tissue a wire has to traverse as well as the length of the tissue to be traversed along the CTO. This feature is determined by the lateral support provided by the wire. Trackability. Trackability is the ability of the device to track over a guide wire during, say, insertion, especially around bends. This feature is determined by the lateral support provided by the wire. Trackability. 1.1 transmission of the bend. Torqueability is the response of the wire to turning to the operator when navigating vessels. The ability to transmit torque from proximal end to the distal end of the wire. This property is important in drilling strategy where wire is rotated in a collateral manner to search for a path of least resistance. It depends on single core wire, lateral support, and wires with dual load composite wire. Steerability. Steerability is the ability of the responsiveness of the wire tip to navigate vessels. Bending. Ability to bend if required to circumvent a very stiff tissue, as for example calcium. While a structure at the end of the wire allows this property, while single core wire resists it. Lubricity. Resistance to encountered while moving the wire in a vessel or through any lesion. Lubricity is the edge of this passage. Resistance encountered depends on the tissue encountered, vessel lumen, microchannel, lipid, plaque, proteoglycan, and collagen elastin. Bends, tortuous lesions. Lesion, length of the lesion. In general, resistance offered as follows: polymer coat, hydrophilic, hydrophobic, and non-coated. Indication. Focal tapered CCO, where tap is soft, Fielder XT and Gaia 1 is enough. Tortuous or microchannel tracking, failure. Intermediate wire, miracle, and ultimate pro. Hard and dense is stiff. That is stiff where Conquest Pro, Gaia 2, 3, Miracle 12. Sequence of guide wire selection in CTO. Yes. CTO lesion type, soft tissue tracking, soft less than 1 gram wire tap load, Fielder XT, A, XTR. Hard tissue tracking, intermediate, 2 to 6 gram, Gaia family. And calcified penetrative stiff, Conquest Pro, more than 9 gram. Current algorithm for wire selection. You see, channel communication. Channel communication is there, Fielder XTR is enough. Tapered and blunt, that Fielder XTA. A hard plaque, Gaia fast, UB3, Gaia second, Pilot 200, Gaia third, Miracle 6. And severe calcifications, that is Conquest Pro group. If stiffness, you can see how it increases with the variety of wires. Complex occlusion wires. Complex occlusion wires these are the wires used in these cases. Tip load is shown. Recommendation of preferred wires for each CTO technique. That is, use XS, Xeon Blue, BMW, run through NS intermediates. It is the description, tip composition, and microchannel crossing, filter XT, filter XTA. Techniques of guide wire handling. Yes, sliding technique, drilling technique. You can see the picture. Penetrating technique, forcible push and torque technique. Microcatheter, wire exchange, floppy to dedicated stiffer, torque to tip, and improve feedback. These tip stemness guide wire. Wire shaping. These are the not good wire shaping type, but the first one is primary bending of 30 to 45 degrees, 1 to 2 millimeter from the tip, find softest part. And this secondary bending 10 to 15%, 3 to 6 millimeter from at 6 to 50 millimeter, work as a navigator to orient tip. These are the two preferred wire shaping. Tip curve should be just larger than the lumen diameter. You see, these are the thing. CTO, the lumen diameter 0 millimeter. For CTO lesion, guide wire tip curve should be very small, and larger curve may hurt the vessel wall during direction control. Guide wire navigation, different methods, sliding, drilling, penetration at proximal cup, inside CTO, and distal cup, respectively. Tactile sensation, feeling of the dimple at the entry point, especially in the abrupt type of CTO entry. Feeling of strong resistance when pulling back the wire inside the CTO body. In this situation, the wire tip has most likely migrated to the subintima. Feeling of non-resistance, the wire tip moves freely. This most likely means that the wire tip is either in the true lumen or in the extravascular space. Stop point, creation of a large false lumen, especially if the adventitial staining is present. Sharing of collateral resulting in loss of visualization of the distal flow, excessive patient or operator fatigue, excessive radiation exposure, as per example, 60-minute fluoroscopy time, excessive dye consumption, second try at 6 to 8 weeks later. IVAS technique is always better for CTO lesion. Forward-looking IVAS, that image confirms catheter is the center in the vessel and catheter is approaching the wall, change direction. Debulking of calcification lesion, these are the methods we can do the debulking procedure. Summary, have clear-cut indications for PCI, proper case selection for operator skills, have a predefined limits of stopping, avoid preventable complications, excess contrast radiation. Failed PC is not a bad outcome. Space 2 may yield better result. Finally, stop questioning. Why should you open the occluded vessels? Start questioning. What is the justification to leave the vessel closed? Thank you for patient sharing.